Welcome to the Physiotherapy Revision series. In this video, we are going to revise osteology or the study of bones. We will cover the basic functions and composition of bone, gross anatomy, blood supply, bone development and ossification, growth plates, common clinical condition, classification of bones, important bony landmarks, and finally bone remodeling and Wolff's law. The focus throughout this video will be on high yield concepts that are important for physiotherapy licensing and entrance examinations. So let's begin. Bone is a specialized type of connective tissue. Although we often think of bone as a hard and inactive structure, bone is actually a living, dynamic, and metabolically active tissue. It continuously undergoes formation, resorption, and remodeling throughout life. Functions of bone. The first important function of bone is support. The skeleton provides the framework that supports the body and maintains its shape. Second is protection. For example, the skull protects the brain, the vertebral column protects the spinal cord, and the rib cage protects lungs and heart. Third is movement. Bones act as levers, while skeletal muscles produce the forces that move these bones around joints. Bone also acts as an important mineral reservoir, particularly for calcium and phosphate. Another important function is hematopoiesis, or blood cell production. In adults, red bone marrow found within certain bones is responsible for producing blood cells. Finally, yellow bone marrow stores fat. So remember the major functions of bone: support, protection, movement, mineral storage, and blood cell formation. Bone is composed of both organic and inorganic components. The major inorganic component is hydroxyapatite, a calcium phosphate mineral. Hydroxyapatite provides bone with its hardness and resistance to compression. The major organic component is type 1 collagen. Collagen provides bone with tensile strength and some flexibility. This combination of collagen and mineral makes bone strong while preventing it from being completely brittle. So, an important exam point is type 1 collagen is the major collagen found in bone. And remember, hydroxyapatite provides hardness and resistance to compression, while collagen provides tensile strength. Now let's look at the structure of a typical long bone. A long bone has three major regions. The diaphysis is the shaft or central portion of bone. The expanded ends are called epiphysis. The region between diaphysis and epiphysis is called the metaphysis. The outer surface of bone is covered by a connective tissue membrane called the periosteum. The internal surface aligned by the endosteum. The shaft contains a medullary cavity which contains bone marrow. The outer portion of the bone is mainly compact bone which provides strength. The ends of long bones contain a greater amount of spongy or cancellous bone. The joint surfaces are covered by articular cartilage, which reduces friction and helps distribute loads across the joint. Bone is a vascular tissue and requires a good blood supply. The nutrient artery enters the shaft through a nutrient foramen and supplies the medullary cavity and much of the inner part of the cortex. The periosteal vessels supply the outer portions of the bone. The metaphyseal and epiphyseal vessels supply the corresponding region near the ends of the bone. The blood supply of bone becomes particularly important clinically because adequate vascularity is essential for fracture healing. If the blood supply is compromised, healing can be delayed or, in some situations, fail to occur. Bone development is called ossification. There are two major types. The first is intramembranous ossification. Here, the bone develops directly from mesenchymal tissue without first forming a cartilage model. This mechanism is particularly important in the development of many flat bones of the skull as well as clavicle. The second type is endochondral ossification. In this process, a cartilage model is gradually replaced by bone. This is the major mechanism responsible for the development of most long bones. The epiphyseal plate or the growth plate is responsible for the longitudinal growth of long bones during childhood and adolescence. There are several zones in the growth plate: zone of resting cartilage, zone of proliferation, the zone of hypertrophy, zone of calcification, and zone of ossification. Once the growth plate closes, longitudinal growth of that bone stops. This is why injuries involving the growth plate in children can have important consequences for future bone growth. Now let's move to some important clinical application. Fracture healing occurs through a sequence of overlapping stages. First is the inflammatory phase. Immediately after fracture, blood vessels are damaged and a hematoma forms around the fracture site. Next comes a callus formation. A soft callus develops and helps stabilize the fracture. This is followed by formation of a hard or bony callus. Finally, the bone enters the remodeling phase. During remodeling, excess bone is removed and the structure gradually becomes more organized according to the mechanical stresses placed on it. So remember the basic sequences: inflammation, soft callus, hard callus, and remodeling. Osteoporosis is a systemic skeletal disorder characterized by reduced bone strength and increased risk of fracture. The amount and quality of bone are reduced, making the skeleton more fragile. Common fracture sites include the vertebrae, hip, and distal radius. Risk increases with aging, reduces mechanical loading, hormonal changes, and several other factors. Now let's differentiate osteoporosis from osteomalacia. Osteomalacia is a disorder of defective mineralization of newly formed bone in adults. Vitamin D deficiency is an important cause. The key concept is that in osteoporosis there is a reduction in bone mass and bone strength. In osteomalacia, the major problem is inadequate mineralization. A stress fracture is a small crack in bone caused by repetitive loading. The problem occurs when repeated mechanical stress exceeds the bone's ability to adapt and repair itself. Stretch fractures are commonly associated with repetitive activities such as running, jumping, and military training. Common locations include the tibia and metatarsals. Clinically, the patient may present with localized pain that is initially related to activity and may progress if loading continues. For physiotherapists, identifying excessive training load and allowing appropriate recovery are important components of management. Bones can be classified according to their shape. The first is long bone, like the femur, humerus, radius, and ulna. Long bones generally function as lever and are important for movement. Next are short bones, like the carpal bones of wrist and tarsal bones of ankle. They mainly provide stability and allow controlled movement. The third category is flat bones, like the scapula, sternum, ribs, and many bones of the skull, which provide protection and surface for muscle attachment. Then comes the irregular bones, like vertebra and some bones of the skull. Then we have sesamoid bones, which develop within the tendons. The best example is patella. Then we have pneumatic bones, which contain air-filled spaces or sinuses, like the frontal, ethmoid, sphenoid, and maxilla. Bony landmarks are extremely important for physiotherapists. They help us understand muscle, ligament attachments, identify anatomical structures, perform palpation, assess movement, and recognize abnormalities. Now let's go through the major terms. A process is a projection from a bone. Processes commonly serve as attachment sites for muscle and ligaments. A tuberosity is a large, usually roughened projection that commonly provides attachment for muscles or ligaments. The tibial tuberosity is a familiar example. A trochanter is a large projection found specifically on the femur. The two major examples are greater and lesser trochanter. An epicondyle is a projection associated with a condyle. For example, the median and lateral epicondyles of humerus. A condyle is a rounded articular prominence. The femoral condyles are an important example. A head is a rounded enlarged end of a bone that usually forms part of a joint. like the head of femur articulates with acetabulum. The neck is a narrowed region connecting the head with the rest of the bone. A facet is a small, relatively fat articular surface. Facets are particularly important in the vertebral column. A foramen is an opening or hole through a bone that allows structures like nerves and blood vessels to pass, like the foramen magnum. A sulcus or a groove is a depression in the bone that may accommodate a tendon, nerve, or blood vessel. A crest is a prominent ridge of bone. The iliac crest is a clinically important example. And finally, a spine is a sharp or narrow projection from the bone, like the spine of scapula. Now, why are the bony landmarks important to physiotherapists? Because they are not simply anatomy terms to memorize. They have direct clinical importance. Many muscles originate from or insert onto bony landmarks. Like the tibial tuberosity is associated with patellar ligament. Greater trochanter is an important landmark around the hip, which provides attachment sites for several muscles. These landmarks help us during palpation and physical examination. We can palpate the acromion, iliac crest, greater trochanter, and various other landmarks to help identify anatomical position and assess musculoskeletal conditions. Bone is constantly being renewed. This process is called bone remodeling. Two major cell types are particularly important: osteoclasts, which are responsible for bone resorption, osteoblasts, which are responsible for bone formation. During remodeling, old or damaged bone is removed and replaced with new bone. This process helps maintain bone strength and also contributes to calcium and phosphate regulation. Now we come to one of the most important concepts for physiotherapists, the Wolff's law. Wolff's law describes the principle that bone adapts to the mechanical loads placed upon it. In simple terms, bone becomes stronger when exposed to appropriate mechanical loading. And when mechanical loading is significantly reduced for prolonged periods, bone mass can decrease. This is why exercise is so important for maintaining bone health. Weight bearing activities and resistance to exercises provide mechanical stimulation to bone. Activities such as walking, running, jumping, and resistance training can promote bone adaptation through the response depends on factors such as age, intensity, frequency, nutrition, and hormonal status. For physiotherapists, this principle is especially important when designing exercise programs for people at risk of bone loss. Now consider the opposite situation. When limb is immobilized for a prolonged period, mechanical loading decreases. This can lead to increased bone resorption and a loss of bone mineral density. This is one reason why prolonged bed rest or immobilization can contribute to significant bone loss. Therefore, when medically appropriate, early and progressive mobilization and weight bearing are important components of rehabilitation. And that brings us to the end of our osteology revision. If you are preparing for a physiotherapy licensing or entrance exam, don't just memorize these terms. Try to connect every anatomical concept with its clinical relevance. We'll continue our revision series with next major topic. Until then, keep revising, keep practicing questions, and I'll see you in the next video. Please like and subscribe.